120/80 has been called the gold standard of blood pressure control for decades, posted on clinic walls, repeated at every checkup, built into every prescription decision your doctor has made for you since you turned 60. But the research those guidelines were built on was conducted almost entirely on adults under 65. Your arteries were never part of that equation, and the target protecting a 40-year-old may be quietly starving a 70-year-old's brain and kidneys of the pressure they actually need to function. Here is what nobody in that exam room has said out loud. The major cardiovascular trials that established 120/80 as the universal BP goal enrolled a median participant age of 52. Seniors over 70 were systematically underrepresented. If you take your medication every single morning, check your numbers faithfully, hit the target your doctor set, and still feel exhausted by noon, lightheaded when you stand, and vaguely unwell in a way no one can explain, that is not anxiety. That is not aging. That may be the target itself. And there is a specific reason why natural compounds interact with aging arteries differently than any pill your doctor has prescribed, and that answer is coming before this video ends. My name is Dr. James. I am a cardiothoracic surgeon with 26 years operating on hearts and arteries damaged by cardiovascular disease in adults over 60. And hypertension management in seniors is where I have seen the most preventable harm. In the next few minutes, I am going to walk you through 5 specific ways. Standard blood pressure treatment affects seniors differently than it affects younger patients. And 3 things you can do starting tonight or at your very next appointment. What is genuinely at stake is whether your heart is being supported or quietly overworked by the number on that prescription label. The number on your prescription was not written for your body. The landmark blood pressure trials that established 120/80 as the universal target, including the research that drove the 2017 guideline revision down to 130/80, enrolled participants with a median age in the early to mid-50s. Adults over 70 were systematically underrepresented in that data, which means the target your doctor has been measuring you against, the one you have been medicating yourself toward every single morning, was calibrated on cardiovascular systems that were decades younger than yours. A 70-year-old artery wall is not the same material it was at 45. Think about an older garden hose that has stiffened over years of use. It needs a certain minimum pressure just to push water from one end to the other. Reduce the pressure too far, and the water barely reaches the garden. Your arteries function on a similar principle. As arterial walls stiffen with age, a process called arteriosclerosis, your body actually raises baseline systolic pressure as a compensatory mechanism. It is not malfunction, it is adaptation. Your cardiovascular system is working to maintain adequate blood delivery to your brain, your kidneys, and your heart muscle under conditions of reduced arterial elasticity. When medication drives that pressure aggressively downward, those organs may not receive the perfusion they require before any visible symptom signals a problem. I have spent 26 years as a cardiothoracic surgeon watching this play out in seniors who did everything right. The number your doctor checks at every visit may be measuring compliance with a guideline, not the actual safety of your blood pressure right now. The downstream effects of chasing a target that was never designed for aging arteries do not stay invisible forever. They show up in 5 very specific ways, and most seniors have been dismissing every single one of them as just getting older. The first thing almost nobody connects to their blood pressure medication is the dizziness that hits when they stand up too fast. Research published in the Journal of the American Geriatric Society and related literature on antihypertensive therapy in older adults indicates that orthostatic hypotension, a transient drop in blood pressure when moving from sitting or lying to standing, may affect up to 30% of seniors on multiple BP medications, in some studies. 30%. And the vast majority of those patients have been told their numbers look great. Here is the mechanism. Diuretics, medications that reduce blood pressure by eliminating excess water and sodium, reduce your total circulating blood volume. ACE inhibitors, artery-relaxing medications that lower the resistance your heart pumps against, reduce vascular resistance simultaneously. In a younger cardiovascular system, specialized pressure sensors called baroreceptors respond almost instantly when you stand, triggering a rapid compensatory squeeze to maintain pressure to the brain. After 65, baroreceptor sensitivity declines significantly. The reflex is slower. The compensation arrives late. In that brief window, your systolic pressure can drop sharply enough to cause lightheadedness, instability, or a near fall. And if you are on both a diuretic and an ACE inhibitor at doses calibrated to hit 120/80 while seated, that window widens considerably. It is essential to say clearly, never stop or adjust a blood pressure medication on your own. The cardiovascular risks of sudden discontinuation are real and serious. This is information for a conversation with your physician, not a reason to alter what you are taking tonight. Orthostatic drops are the visible effect. The less visible consequences are operating inside your brain and your kidneys right now, and those are where the long-term damage from overtreatment quietly accumulates. Your brain requires a minimum perfusion pressure to maintain normal cognitive function, and in seniors with stiffened cerebral arteries, research suggests that driving blood pressure down to 120/80 may actually reduce blood flow to regions of the brain that depend on a slightly higher systolic to receive adequate circulation. Studies in the Lancet Neurology category and cerebrovascular medicine journals have examined the relationship between aggressive BP lowering and cognitive outcomes in adults over 70, and the findings point consistently in one direction. The brain's autoregulation system, its mechanism for maintaining stable blood flow across a range of pressures, shifts its lower functional threshold upward with age. A 70-year-old brain may autoregulate optimally at a systolic of 140 to 150, not 120. Push below that threshold pharmacologically, and the result can be subtle but cumulative. Cognitive fog that arrives gradually, fatigue that deepens over months, word-finding difficulty that gets attributed to normal aging, when it may actually be a brain receiving less pressure than it needs to function at its best. If you experience any cognitive symptoms, memory changes, unusual fatigue, difficulty concentrating, those need to be evaluated by your physician directly. The point here is not to self-diagnose. The point is that these symptoms may have a cardiovascular explanation that no one has raised with you. I want to ask you something directly. In the comments below, tell me what BP target your doctor gave you, and whether you have been experiencing fatigue or brain fog that you have always assumed was simply part of getting older. Share the specifics of your experience. You would not believe how many people describe the exact same symptoms after reading their number is perfect. The brain is not the only organ running on pressure it was never given a chance to ask for. The kidneys are doing something almost identical, and the consequences there show up in lab numbers most seniors have never been taught to watch. Kidney function naturally declines by approximately 1% per year after the age of 40. That is baseline aging. What accelerates that decline is reduced perfusion pressure to the kidneys themselves, and aggressive blood pressure lowering may do exactly that. The kidneys filter blood through a pressure gradient, a measurement called glomerular filtration rate, GFR, the number that appears on your annual blood work, depends on adequate pressure in the small arteries feeding the kidney's filtration units. ACE inhibitors and ARBs, two of the most commonly prescribed artery-relaxing medication categories for hypertension, reduce that pressure gradient as a direct part of how they work. In younger patients with intact nephron mass, this is a protective effect. In seniors with already reduced filtration capacity, research published in the American Journal of Kidney Diseases and related nephrology literature indicates this same mechanism may reduce GFR to a range that quietly accelerates chronic kidney disease, with no pain, no symptoms, no warning until the numbers shift far enough to matter. The lab number your doctor reviews at your annual checkup may be drifting in the wrong direction, and the medication managing your blood pressure right now may be part of what is driving that drift. Gerald was 73 years old, retired engineer, the kind of patient every cardiologist describes as model. He checked his blood pressure twice every day, never missed a dose, and consistently produced readings of 118/76. His general practitioner praised his numbers at every visit for 3 years. Gerald came to me after 2 near falls in 3 months that his GP had attributed to getting older. When I reviewed his medications, he was on a diuretic, a blood volume reducing agent, combined with a beta blocker, which slows the heart rate and reduces cardiac output. Together, at the doses calibrated to maintain his seated reading at 118, they were producing orthostatic drops of 25 millimeters of mercury systolic the moment he stood. His blood pressure was perfect while he sat in the clinic chair. The moment he stood to walk to the bathroom at 3 in the morning, his brain was receiving pressure more than 20 points below what it needed. A single medication adjustment moved his resting systolic to 134. His morning dizziness resolved in 2 weeks. His doctor had prescribed correctly by every published standard. The guidelines simply had not been designed to account for how Gerald's 73-year-old baroreceptors would respond. For seniors over 75, research increasingly supports that a systolic target of 130 to 140 may be more protective than 120, individualized for fall risk, kidney function, and existing conditions. That is the answer. Not one number for every age, a range calibrated to the body, actually in front of the physician. What compounds every mechanism described above, the orthostatic drops, the cerebral and renal hypoperfusion, is a pharmaceutical side effect so common in seniors on long-term BP treatment that it has a clinical name, and yet most patients have never been warned it exists. Thiazide diuretics, among the most widely prescribed blood pressure medications in adults over 60, do not just reduce blood pressure by eliminating sodium and water, they eliminate potassium simultaneously. That is not a rare adverse reaction. That is the mechanism. Potassium is required for normal cardiac muscle contraction and for the electrical signals that keep your heart rhythm stable. Magnesium, which is also depleted by long-term thiazide use, is required for the cellular pumps that maintain potassium balance inside cardiac cells. Lose both over months and years, and you have a heart that is working harder against a lower pressure with reduced electrolyte support. And research in cardiology and pharmacology literature on diuretic-induced electrolyte changes indicates this combination is associated with elevated arrhythmia risk in adults over 65 in some studies. Seniors eating lower-calorie diets, which is most people over 70, have a smaller dietary buffer against these losses than younger patients taking identical doses. I want to stop here for a moment, because this particular point is personal to me. Early in my surgical career, I operated on a 68-year-old woman named Margaret who arrived in atrial fibrillation, an irregular, often dangerously fast heart rhythm, after what had initially appeared to be a routine hypertensive episode. Her potassium on admission was 3.1 millimoles per liter, low enough to destabilize her cardiac conduction, not low enough to have alarmed anyone at her last 2 clinic visits. She had been on a thiazide diuretic for 4 years. Her potassium had never been tracked quarterly. I replayed that case for a long time afterward. It changed how I approach every senior patient on long-term diuretic therapy. Potassium monitoring in this population is not a box to check once a year. It is active cardiac protection. Please never supplement potassium on your own without physician guidance. Too much potassium, hyperkalemia, carries its own serious cardiac risk, and the danger increases significantly for anyone already on ACE inhibitors or ARBs. This conversation belongs in your doctor's office. Everything described above, the electrolyte depletion, the perfusion deficits, the orthostatic risk, is being compounded every single day by the one piece of advice every senior on blood pressure medication has received and never been told to question. Drink more water. Plain water. Simple. Obvious. And for seniors on diuretic therapy, potentially making the electrolyte problem worse with every glass. After 60, thirst sensation becomes less reliable. The physiological signal that tells you to drink dulls with age, meaning you are already working with impaired hydration cues. Renal concentrating ability also declines, so your kidneys are less efficient at retaining what the body needs. Plain water consumed alongside diuretic medication may increase urine output without replacing the potassium and magnesium lost through that increased excretion. You drink more, you urinate more, and the mineral deficit described in the previous item deepens further. Research published in the European Journal of Clinical Nutrition and related nutrition cardiovascular medicine literature suggests that hydration quality, specifically the mineral content of what seniors drink and eat alongside their fluid intake, may be a meaningful variable in blood pressure outcomes, not a peripheral one. This is not about drinking less. It is about drinking differently. And the specific shift that research suggests may support blood pressure management in seniors more directly than plain water is exactly where this conversation is headed. Before getting to those actions, something important needs to be said. Because a thought may have been forming throughout everything above, and it deserves a direct answer. Your doctor went to medical school. They have treated hundreds of patients, read thousands of pages of research, and have access to the same published literature. If the guidelines are inadequate for seniors, why has none of this ever come up in your appointments? That is a fair question. And the answer is not that your doctor is indifferent to your well-being. Physicians follow the guidelines they were trained on and the protocols approved for their patient population. That is not a failure of individual care. That is how standardized medicine is designed to function consistently across millions of patients using the best available evidence. The problem is upstream from your doctor entirely. The populations that generated the data behind current hypertension guidelines were, on average, younger, healthier, and less medically complex than a 70-year-old managing hypertension alongside 2 or 3 other chronic conditions. The adults most affected by those guidelines were the adults least represented in the trials that created them. Your physician did not design those trials. They are working from the most rigorous standardized guidance available. Guidance that was not standardized for someone your age, with your arteries and your specific physiology. I have seen this gap from both sides of the operating table. The doctors ordering these prescriptions are not the adversary. The adversary is a guideline infrastructure that moved slowly while the population it was treating aged rapidly. What changes now is that you are no longer waiting for the system to catch up. You are walking into your next appointment with specific questions. And that changes the conversation entirely. The information you now have about your blood pressure right now is not background knowledge, it is clinical leverage. First, tonight, write down the exact BP target number on your current prescription, not what you remember it being, the actual number. Write alongside it every symptom you have been attributing to aging: the dizziness when you stand, the afternoon fatigue, the mental fog that settles by mid-morning. These are not complaints, they are data points. At your next appointment, you have every right to ask, is this specific target appropriate for my age, my kidney function, and my fall risk? That is not confrontation, that is informed medical participation. Second, tomorrow morning, add 1 potassium-rich food to what you eat: a banana, a sweet potato, or half an avocado. Research suggests that adequate dietary potassium may support healthy blood pressure management in seniors alongside medical care, and given what diuretic therapy does to potassium levels over months and years, this is one of the simplest reinforcements available. Not a substitute for medication, a nutritional support layer that your prescription was never designed to provide on its own. Third, at your next appointment, ask your physician directly, do any of my current blood pressure medications carry orthostatic hypotension risk? And has my blood pressure ever been checked standing up, not just seated? That single question may open the conversation that Gerald's story illustrated so clearly. Research suggests that specific dietary changes, targeted hydration, and electrolyte awareness may meaningfully complement medical blood pressure management in seniors. Not replace it, reinforce it. The information your doctor's 12-minute appointment has never had time to give you is now yours. That gap is closed. Here is what this conversation has covered, because these 5 points deserve to land clearly. The blood pressure target your doctor gave you was built on research conducted predominantly on adults under 65, and for seniors over 70, A systolic of 130 to 140 may be more protective than 120, depending on your specific physiology. The dizziness you experience when you stand up fast is not an inevitable consequence of aging. It is a documented side effect of antihypertensive medications in seniors, and it is frequently unaddressed. The cognitive fog and fatigue that arrived gradually after your blood pressure came under control may reflect cerebral hypoperfusion, a brain receiving less circulating pressure than aging arteries require to deliver adequate blood flow. Your kidney function numbers may be drifting quietly in the wrong direction, driven in part by the same medications reducing your blood pressure below your kidney's own filtration threshold. And the potassium and magnesium your heart muscle depends on for stable rhythm and contraction are being depleted by the diuretic in your prescription. Not as a side effect, as a mechanism. Drop your number in the comments. Tell me what BP target your doctor set for you, and whether you are planning to ask about an age-appropriate target at your next appointment. Share what you have been experiencing. Your story matters, and it helps everyone reading below you recognize that they are not alone in this. If someone in your life takes a blood pressure pill every morning and has never once asked whether the number on that prescription was designed for someone their age, send this video to them today. That is a conversation worth having before the next appointment, not after. In the next video, I am covering 3 natural compounds that research suggests may support healthy blood pressure management in seniors more effectively than standard dietary advice, and one of them is already sitting in most people's kitchens right now. Make sure you are subscribed so you see that one when it comes out. Walking into a doctor's appointment with one written question is not a small act. It is what informed self-advocacy actually looks like. And after everything your heart has quietly absorbed from guidelines that were never built for it, asking that question is the most direct form of care you can offer yourself. I am Dr. James. I will see you in the next one.